Hello, friends. So, my name is Dr. Ashish Goyal, and I'm a professor and head of the Department of Medicine at the Ambedkar Institute of Medical Sciences in Mohali. And today, we are going to talk about an approach to a patient who presents to us with anemia. So, let's talk about what is anemia. So, according to the WHO definition, females with a hemoglobin of less than 12 and males less than 13 qualify for being called anemic. The first thing that you do when you get a laboratory report is to check for the indices. If the MCV is less than 80, we call it microcytic. Between 80 to 100, it's normocytic, and more than 100, it's a macrocytic anemia. Look for the history and examination. If you find that the patient has history of pica and has cholionicia, look for the laboratory parameters again. You find that platelets are increased, the red cell distribution width or the RDW is increased. You find on peripheral smear there are pencil cells. Check the Menser index and do the iron studies. Now, what is Menser index? So Menser index is calculated by MCV divided by the RBC count. What is iron studies? So iron studies include the estimation of serum iron, serum ferritin, total iron binding capacity, also called TIBC, TSAT, which is the transference saturation. So if you find that the serum iron and ferritin are low, TIBC is normal or increased, and transference saturation is low, then you diagnose an iron deficiency anemia and start looking for causes of iron deficiency anemia which could have led to this stage, which could be nutritional, there could be menorrhagia or GI loss, and there could be malabsorption. Now, in case you find that the history is suggestive of diseases like tuberculosis or rheumatoid arthritis, collagen vascular diseases, or malignancy, and you find that the RDW is normal and you're not finding anything specific on the peripheral smear, you diagnose anemia of chronic disease and you start looking and managing the disease which is underlying there or which is present in the underlying stages of the patient. If you find that there is a family history suggestive of anemia and you find that on the indices RBC, the number of RBCs or the count of RBCs increased, the RDW is normal, you find that there is basophilic stippling or target cells on peripheral smear, you find that the Menser index that we just discussed is less than 13 and HbA2 is greater than 3.8 on electrophoresis, then we describe or identify this patient as having a thalassemia trait. Now, if you find that the iron loads are increased, they are more than normal, then you diagnose this patient as sideroblastic anemia. While if you find that there are blue lines on the gums of the patient and there are nail changes which are compatible with this, then we find and identify this patient to have a lead intoxication. So the key things to remember in a microcytic anemia is that you want to find out the cause of anemia of microcytic nature, which could be iron deficiency anemia, anemia of chronic disease, thalassemia, sideroblastic anemia, or a lead intoxication. Now, if you have a normocytic anemia and you check the indices and you find that the RDW is increased, you find that there is anisopoikilocytosis, that means the sizes of the RBCs are variable and different. You check for the vitamin B12 levels and do the iron studies, and you find that there is a dimorphic anemia. That means there is a deficiency of vitamin B12 as well as there are low iron levels. Then you treat as dimorphic anemia by supplementing both these nutrients, vitamin B12 and iron. If you again find that there is a history of chronic disease, you diagnose anemia of chronic disease, and the most common disease which is presenting as normocytic anemia in cases of chronic diseases is a chronic kidney disease. Now, if you find that there is pancytopenia in this individual, you check for the retic counts, which is decreased, and you check the reticulocyte index, and you find, let's see, what's a reticulocyte index? Now, reticulocyte index, also called the reticulocyte production index, or the corrected retic count, which is calculated by multiplying the identified retic count, reported retic count in the laboratory, You multiply this with the ratio of the patient's hemoglobin by the normal hemoglobin from the lab report. And in this case, where you have found there's a normocytic anemia and there is a pancytopenia, you go ahead and do a bone marrow aspiration and biopsy, and you find that there is a marrow failure or a disturbance in the marrow. You start looking for a specific cause, which could be between aplastic anemia or a myelodysplastic syndrome or a leukemia or a multiple myeloma, or there might be an infiltrative disorder where the bone marrow has been infiltrated. Now, supposing you find that there is macrocytosis. Now, if there is MCV greater than 100, you look for the retic count and you find that the retic count is increased. The retic count index or the reticulocyte production index is more than 3%. You check for polychromasia on the peripheral smear and you found that the indirect bilirubin is raised. Well, this could also be a feature in some types of normocytic anemia, in which if you check the retic count and find that the retic count is similarly increased, then you go ahead and label this as a hemolytic anemia. Among the hemolytic anemias, then you need to further work up and see whether it's a autoimmune hemolytic anemia by doing a Coombs test. You look for a sickle cell disease, which might be evidenced on a peripheral smear by sickling, or an electrophoresis, which might show that there is sickling. Now, then there is the osmotic fragility test, in which you could look for spherocytosis. You look for G6PD levels by identifying a G6PD deficiency. A peripheral smear might also show evidence of infections or hematological infections such as malaria or babesiosis. If there are schistocytes present on the peripheral smear, try and look for a history of prosthetic valves, and on flow cytometry, we check for paroxysmal nocturnal hemoglobinuria. Now, if you find that the types of macrocytes or round macrocytes are seen, we try and label it, we identify this as macrocytic anemia, which could be due to drugs or alcohol. Now, the common drugs which cause macrocytic anemia would be hydroxyurea, methotrexate, azathioprine, or trimethoprim. If there are macroovelocytes or oval macrocytes, and there is a possibility that many of the macrocytic anemias may also have a component of pancytopenia, you find that there is hypersegmented neutrophils in the peripheral smear, platelets are reduced, vitamin B12 levels are low, and homocysteine is high, then you label this as megaloblastic anemia, and you further work up to find out if it's nutritional or there is malabsorption or there is a pernicious anemia in which there is an intrinsic factor deficiency in this individual. Another question which is sometimes asked is about anemias which can present as pancytopenia. So there is different kinds of anemias which may present as pancytopenia. Like already said, there could be aplastic anemia, myelodysplastic syndromes, and others which could present as a marrow failure. But in addition to that, even megaloblastic anemia or a paroxysmal nocturnal hemoglobinuria or a Fanconi's anemia may present as pancytopenias. So with this, we come to an end of today's session. Thank you so much for staying till the end and listening to this. I hope you enjoyed this, listening to this as much as I enjoyed bringing it to you. And thanks for stopping by. See you again.